Hello, I can hear you still talking about how exciting that activity was. It's really fun seeing your faces and how focused you were doing it. We were very glad with adding these physical therapy sessions. There is more than physical, as you saw. It's also cognitive therapy. I am taking the advantage of all of you being here, kind of wrapping up way before the end, because you are going to listen to our kind of keynote guest speaker, Professor Shannon. Before introducing her formally, just a few housekeeping announcements. On October 23rd next year, we are going to have our next symposium, so you are all welcome to come. We do appreciate your feedback. That's why you have evaluation forms, I think, in the bags that you all got when the entrance. If you can give us those forms with your feedback, that would be very important. This year, for the first time, we could videotape this event. We are going to try to post it on our website so people that couldn't come can access the information. And you also have, if you have not browsed this information, the presentations from the previous symposiums, the last 5 at least, are online, so you can access the information. I do want to thank, I don't know if Starlene Mounier is there. Star, are you here somewhere? She's working. Maybe she can come in. Well, there's Nancy there as well that is calling Star, but I wanted to thank Starlene. That is the kind of the mother of the symposium. If Neil is the father, Starlene is the mother, working very, very hard to make this live. And I think she does deserve more than a big round of applause, but we'll give her a round of applause. So, thank you very much. Yeah, there she is in the back on my left. I do want to thank the students and Nancy Young that has been helping us to get the support for the symposium as well. So thank you, Nancy, and all the students working here. Yeah. And again, one very important final comment before introducing Dr. Shannon. I will ask Dr. Hermanovitz to come to the podium.
So I was watching that exercise with Betsaida with interest. I saw a fellow on a plane one time. He had a T-shirt that said, "I was addicted to the hokey pokey until I turned myself around." So these symposia have been great, I think, over the years that we've done them, and I've really enjoyed the opportunity to interact with all of you and appreciate your interest in coming out. And I did want to let people know that I'm retiring from UCI. Next month will be December 10th will be my last day in clinic. And I will be relocating to Santa Fe, New Mexico, where I hope my wife and I used to live in the past in New Mexico and enjoyed it and have friends there, and hope to continue doing some clinical work in the local hospital in Santa Fe. Just make everybody aware of that. And again, thanks for coming out. And now we can have you can introduce Dr. Shannon? Okay, sure.
Well, again, I really want to thank Dr. Hermanovitz for allowing Dr. Morenkova and me, Dr. Cochran, join his clinic over all these years. So again, thank him. And you all know where he is at, so you can find him, Santa Fe, New Mexico. He's welcome, all of you there, if you want. Thank you. And now it's my pleasure as well to introduce the guest speaker, Dr. Shannon. She's a very experienced Parkinson's disease doctor and clinician. She trained in Chicago under Dr. Klawans, one of the fathers, again, of the field in the United States. She did her medical training, her residency, her fellowship, many years of faculty at Rush University. She has published a lot in the field of Parkinson's disease, dopamine agonist for Parkinson's disease, Huntington's disease trials. She advises the research agencies for the government on research that is done in this field. So she's a very positive and influential leader in the field. And we have our pleasure to have her here talking about her very special research on the gut and Parkinson's disease. So welcome, Dr. Shannon.
Well, thank you for the invitation. It's really special to be able to come and see such a wonderful group of people who are so motivated to make their lives better and to learn about the science and the care of Parkinson's disease. I'm not here with the answer to Parkinson's disease. I wish I had it. But I'm really here to talk about how one approaches questions about Parkinson's disease. How do you put together a research program and look at things, answer the questions that you want to answer? And ultimately, every researcher in Parkinson's disease has one goal, which is to bring new treatments to the market and ultimately a cure. But in order to do that, you already heard this a little bit from that brilliant earlier talk, part of it is identifying what are the things that seem to contribute to the disease genesis, the onset of the disease. What targets might you be able to modify with a potential intervention? So that's what we're going to talk about today. And a lot of people, gastrointestinal issues are very common in Parkinson's disease, so people are aware of this. And I just want to talk about how they might be involved in the actual disease onset or maybe progression. So to go back to 1817, this is James Parkinson's original description of Parkinson's disease. He did this without seeing patients in the office, just by observing them on the street, and defined it as involuntary tremulous motion with lessened muscular power in parts not in action, so parts at rest, and even when supported with the propensity to bend the trunk forward and to pass from a walking to a running pace, the senses and intellects being uninjured. It's a pretty good description of the movement aspects of Parkinson's, but in fact, we all know that sensation is affected as well as intellect or cognitive functions also affected. So that was in 1817. 1912 is when we first learned about what's happening in the brain cells in people with Parkinson's disease. And this was, people have heard about Lewy bodies or Levy bodies, which is the more appropriate pronunciation. So these are collections of like blobs that happen in the brain cells. So this was discovered in 1912. It wasn't clear what they were. They're protein accumulations in the brain cells, first in 1912 and then later in 1923. And associated with were changes in what we call the substantia nigra, which is the pigmented area of the midbrain. So it was known that the generation of these cells underlies the motor abnormalities of Parkinson's disease. And so we knew something was happening in the brain cells. We weren't exactly sure what it was, and it took a long time to figure out exactly what that was. And this happened in 1997. When a family of people with very prevalent Parkinson's disease were examined and found to have a genetic mutation in basically the genetic recipe for a protein called alpha-synuclein. And that what was happening in those people is that alpha-synuclein, which was being made improperly within the brain cells, was accumulating and causing these accumulations of protein that had been noticed under the microscope way back in 1912. And maybe people thought this could be just limited to those people who had that particular genetic mutation, but in fact it wasn't. If you looked at people with garden variety Parkinson's disease, no family history, they have the same protein accumulation. So that was really important, and it helped us to understand that the protein accumulation was the first step in what's going to happen to these brain cells and ultimately result in their death. And as more brain cells die, there's an accumulation of these kind of characteristic motor features of Parkinson's disease. So the next thing to ask is, so we know that there's this genetic form of Parkinson's. We know that it's extremely rare. Since 1997, there have been about a dozen genes that have been discovered to cause Parkinson's disease. But they're all really rare, and the vast majority of patients do not have a pure genetic form of the illness. However, we know genes are important because if you have a family history of Parkinson's disease, your risk is at least double that of someone who doesn't have a parent affected, for example, with Parkinson's disease. So we know there must be a genetic risk. But we also know that there must be an environmental risk, and we've touched on this earlier today when we talked about things like toxins in the environment. There are other things like head injury and occupation, all kinds of things that seem to be associated with increased risk. And at the same time, there are things that are associated with decreased risk. So this looks like a fairly complicated cartoon, but I want you to start here at this gray box all the way on the right-hand side of the slide. So this is the clinical picture of Parkinson's disease. So here over the real point of this arrow is Parkinson's disease diagnosis. So at some point, a person will cross the threshold where they have movement signs that are clearly indicative that the person has Parkinson's disease. That's when we're able to diagnose the Parkinson's disease. But a lot of stuff has happened before that happens. So and the average age of Parkinson's disease diagnosis is around 60. But we know that before that diagnosis, people will have had symptoms for some time, sometimes years, sometimes months. And those symptoms will be the ones that we know are the core features of the disease, like tremor and slowness and rigidity. And before that even, there is a phase of the illness that we call the prodromal phase, which means that there are changes in the body that are happening as a result of the Parkinson's disease, but they aren't those movement problems that allow us to make the diagnosis. And so these are things like olfactory impairment, so a decrease in the sense of smell, constipation. This is going to come back to inform why I went the direction I went with this research. But also problems with sleep, depression, anxiety, changes in thinking and memory, and then other problems with what's called the autonomic nervous system, which is the part of the nervous system that regulates blood pressure and heart rate, those kinds, and bladder function, et cetera. And we think that during life, in this prodromal period and in the early disease before it's diagnosed and the diagnosis, there probably are environmental modifiers. Now, your genes are present from birth, but during this time, there probably are things in the environment that are increasing, decreasing, somehow modifying that progression through this arrow I'm showing you. And before this prodromal period, there's really kind of the genetic background. So these are the genes you're born with, but probably even in that very early stage of life, there are environmental modifiers that may trigger the disease. So if we talk about things like air pollutants and pesticides, metals, viruses, diet, or things that we just don't understand. So there's this kind of, and one of the problems with all the studies that Dr. Hermanowitz and I have participated in, trying to find something to slow or stop disease progression, is that often we don't enter the picture with those drugs until right here, right at the end of this process. And we need to find a way to move earlier, first of all, and take advantage maybe of some of these prodromal symptoms to find targets and maybe find a way to start the treatments earlier. And then and only then maybe we can slow down or stop the progression of the disease. So I'm just going to get back to constipation because this is one of the things, there's several different things that led us to go down this pathway of the gut and Parkinson's disease. So there was a study called the Honolulu Asia Aging Study. And this was a study of cardiovascular health in men of Japanese ancestry who were living on the island of Oahu in Hawaii. And these people started out with about 8,000 people, and they're followed for years to see what were the risk factors for developing heart disease. And then, as people do, they just kept getting older, and people started to follow this same cohort of men to see what the risk factors for Parkinson's disease were. And so they found out all the people had Parkinson's disease, and they were able to go back and look at the data they'd collected over years and years and years to find out what those things were. And several things appeared from that study. So one of them was the complaint of excessive daytime sleepiness. People who said, I'm sleepier than normal, they had a higher risk of being diagnosed with Parkinson's disease over the course of the study. And anxiety and depression and loss of sense of smell. But I'm focusing here just on constipation. So the way to read this slide is that overall, all the people who were studied here, there were almost 7,000 people, of whom 96 developed Parkinson's disease over the course of the study. And they calculated that what's called the incidence rate, which is the number of people per 10,000 persons followed for a year each, basically, is 7.5 of those people would get Parkinson's disease. And then they looked at the number of bowel movements these men had in a day. So 289 of the men had fewer than one bowel movement a day, so they did not move their bowels every day. 426 moved their bowels more than twice a day. And what was found in this study was the fewer bowel movements you have, the higher that number went up. So instead of 7.5 per 10,000 person years, that number went up to 19.6. So a significant increase in the risk of being diagnosed with Parkinson's disease. Whoops, sorry. And then if you looked at people men who didn't have one bowel movement a day, despite taking laxatives twice a week, so they were trying to have a daily bowel movement, that risk was even higher, so 51.6 per 10,000 person years. So what this slide tells you is that people with constipation have a higher risk of being diagnosed with Parkinson's disease over the years. And it was thought maybe that was a risk factor, but now we think it's just an early symptom, like that slide I showed you, one of the prodromal symptoms. And the other thing that was found is that those synuclein accumulations, that protein accumulations in the brain cells, men who died who'd been in the study and agreed to autopsy, having fewer than one bowel movement a day was associated with a lot more of that protein burden in the brain cells. So it's kind of an interesting thing. So that's one reason to think we should look at the gut. There's also other evidence. Again, this is epidemiology research where you look at populations and see who got sick and what differentiates them from people who didn't get sick. So one of those shows that if you have appendectomy, especially if it's more than 10 years before you're in the age range for Parkinson's, having had appendectomy decreases the risk of Parkinson's disease. So again, interest in the gut. Something called vagotomy in the old days, before we realized that ulcer was a bacterial illness. They used to cut the nerve to the stomach in order to reduce acid in the stomach. And that, if you had that early enough in life, that also decreased the risk of Parkinson's disease. And then the third, and I think most interesting thing, is that it was discovered that people who have diseases characterized by inflammation in the gut, so ulcerative colitis and Crohn's disease are the names of those, had about a 28% increased risk of Parkinson's disease. That doesn't sound too convincing, but then it was discovered that people with these inflammatory bowel disease who took a certain kind of anti-inflammatory medicine to treat those conditions had a 78% reduction in that increase in risk. So this kind of raised the possibility that inflammation in the intestines might drive a process that ended up causing brain cell death, and that if you could treat the inflammation in the intestine, you might be able to prevent that brain cell death. So this is really interesting work. These drugs, this kind of anti-inflammatory drug doesn't cross into the brain, so it has to be treating the inflammation in the intestines. So let's talk a little bit more about why intestines and Parkinson's. So there's that kind of tantalizing epidemiology. So the first thing is, if there's an environmental contributor to Parkinson's disease, the more surface area of exposure to that potential toxin, the more likely it is to be important. And so I always learned in medical school that the skin had the greatest surface area of exposure, but the skin is engineered to keep almost everything out. It's a very good barrier. The intestines, if you spread them out, are the size of about a studio apartment. That's how big the intestines are if you spread them out. And so really, really big, and the largest, in fact, surface area. And you might think that they're your insides, but in fact, you're like a donut. You've got a hole through the whole center, right, that starts here and ends here. So those are your outsides. It's just that they're your outsides inside. So that's the largest area of exposure to a toxin. So that's the first thing. The second thing is to think about, what does the intestine do? So it's got two essential functions. The first one is it's a barrier. It's a selective barrier. It lets in nutrients, proteins, carbohydrates. It lets in all that stuff. And it keeps out toxins and bacteria. So it keeps those things out. So those are two really critical functions. The next thing to know, actually, is that there are 100 million nerve cells in the intestines. 100 million. It's called the second brain. It's the second biggest population of nerve cells in the body. And then the last thing, and we were very interested in this part, is that because it's your outsides, just like your skin, it is covered with bacteria. Your intestines are covered with bacteria. Your skin is covered with bacteria. So 100 trillion bacteria. If you consider all the genes that contribute to your function, there are 10 times as many bacterial genes in and on your body than human genes. So the bacteria are really driving the bus a little bit here, and it's important to kind of pay attention to them. Many of those bacteria produce toxins. We were particularly interested in a toxin called lipopolysaccharide, which is produced by bacteria in the intestines. And if you inject lipopolysaccharide into the brains of a mouse, you'll give them a kind of experimental Parkinson's. So we know that this toxin can cause the kind of brain cell loss that we see in Parkinson's disease. So that's really why we're interested. And then the last thing is that these nerve cells, which are, so this is a cross-section of the gut. So the reason the gut is so big is it's got all these little fingers that stick up, which increase the surface for absorption, and they're called villi. And then right next to that is a layer that's got nerve cells in it, or nerve fibers in it, and then there's an outer layer of nerve fiber. And the other interesting part about this is that these nerve cells have a direct connection to the lower part of the brain where the Parkinson's disease protein first appears. So one of the theories about gut involvement in Parkinson's is that that protein that we see in the brain cells could be first accumulating in the nerve cells in the wall of the intestine and then being transported up into the gut. That may not be the reason, but that's one of the other reasons to think about this. So that direct connection to a critical brain area. So the first thing we wanted to look at, and so what we did was we put a study together. I thought there's no way anyone's going to participate in this study, because what the study was is we recruited people with Parkinson's disease who were willing to have a biopsy of their colon and willing to do some other kind of testing of intestinal barrier, where they had to eat a bunch of sugar and drink a bunch of sugar and collect their urine. So we thought this is just going to be a nuisance. But in fact, patients signed up for this. So it was a 2-visit study where they came in and we measured the severity of their disease. We sent them home with these jugs to collect their urine and some sugar to drink. And then they came back in with the jugs of urine, and then they had a sigmoidoscopy, which is like a colonoscopy, just not as far, with the chunks with 9 pieces of colon taken. These are brave and wonderful people. So the first question we asked, is the barrier working? If the barrier's not working, could toxins be getting in and causing or contributing to the cause of Parkinson's? So I'm just going to show you what the barrier looks like. Again, these are the little finger called villi. These are individual cells. That's the nucleus where the DNA lives. And the barrier function, so obviously some things could get through the cells. So it could get from the lumen, where all your food and stuff is, into the tissue of the body by going through the cells. But mostly what happens is that there is a movement between the cells. And there are proteins within the cells, now we're really talking about the microscopic level here, that are called tight junction proteins. So they attach between the cells and prevent stuff from getting in that doesn't need to get in. That makes sense? So they're called tight junction proteins. We're going to come back to those later. And that helps to prevent that. The other kind of basic protections are there's a mucus layer on top of those little fingers, and that helps to keep things out. Now, up here in this cartoon, so down here is the immune system, basically, which we'll talk about a little bit later. But up here now are the things that can disrupt barrier function. So actually, if you use non-steroidal anti-inflammatory drugs, that can disrupt like the ibuprofen. Aspirin is actually the biggest culprit. That can actually make your gut a little bit leaky. So if you're allergic to foods, part of food allergy often is leakiness of the gut. If the bacteria that live in your intestines are not appropriately balanced, that can cause your gut to be leaky. Gliadin, which is people who are gluten sensitive, that's the mechanism. They can get a leaky gut. If you eat too much fat, high-fat diet can cause that, and if you get an infection, then you can cause it. So there are various things that can cause intestinal leak. So in order to test for leaky gut, what we do is we give the person a solution of sugars. There's some tablets and then some sugar that they dissolve in water, and then they drink it. These sugars are not well absorbed. So for example, sucralose is one of the sugars we give. Sucralose is used to artificially sweeten diet drinks because it tastes sweet because it's a sugar, but you don't absorb it, so you don't get the calories. So that's the kind of sugar that we use. And then we assume if the gut is leaky, that sugar is going to get absorbed into the bloodstream. It's going to get filtered out by the kidneys, and we're going to be able to measure it in the urine. So that's why we have people collect their urine. So what did we find? So this is a graph, and so this is each one of these boxes is an individual patient. I'm actually the leaky one here. I was in the study too, but that's me. So this is individual percent of the amount of sugar that they ate that came out in the urine, or we ate that came out in our urine. And then right here's the average number, this line right here. And so those are the healthy people, and this is the Parkinson's disease subject. And you can see much more sugar came out, more than twice as much sugar came out. Therefore, people with Parkinson's disease, these patients with very early disease, 1.5 years on average from diagnosis, from onset, from 1.5 years, had this leakiness already. So then the next thing, so now I've given you a little tiny cut of that figure I showed you before about the intestinal barrier, showing those proteins again. Those are called occludin, claudin, and ZO1. And I'm just showing you one picture. So this now is from the tissue that we took from the biopsies. And you can stain it with what are called immunostains that will attach to certain things. And so we stained this tissue for claudin, one of these proteins. We've also done similar work for another protein called ZO1. And up here are the healthy people, and down here are the people with Parkinson's disease. And what you can see is there's much less intensity of that color in the Parkinson's disease subjects. It's this red color. And that's because people with Parkinson's disease have lost the integrity of those proteins that go between the cells and prevent leak. So this is an important finding. So we have then concluded that people with Parkinson's disease have leaky gut. So let's move on a little bit to the immune function. So when you think about immunity, immunity protects you from invaders, foreign invaders, bacteria, certain other kind of foreign things. And it's important, but it does that by releasing things like cytokines and activating cells whose job it is to destroy those invaders. And that's great. But inflammation can also be harmful to the tissue, to the healthy tissue. So too much of this immune function can be a problem. And the way we looked at this several ways. I'm just going to show you one. But by the production of cytokines. So cytokines happen when the cells in the immune system sense either damaged tissue or an invader, a pathogen. And then they secrete the cytokines that are released from the cells, and then they enlist the help of other immune cells to go and attack whatever that problem is. And as I said, it's great, but if it's uncontrolled, it can actually cause tissue damage. So the way we did this was, again, we took those pieces of the intestinal wall and we tested them for cytokines. And we found, and so this column here is healthy people, and this is Parkinson's, and this bar is taller, meaning that the Parkinson's patients have more of these cytokines. And there are things called, there's one called interleukin 17A, this is one called interferon gamma, this is one called interleukin 1 beta. These are all cytokines that cause inflammation. And then down here is one that's an anti-inflammatory. It's actually helps balance the inflammation, and the anti-inflammatory chemicals are actually less in Parkinson's. So more inflammation, leaky gut, more inflammation, less anti-inflammatory activity. The next thing we looked at is there are specialized areas on these immune system cells that help to detect when there's an invader. They're called toll-like receptors. And there's a bunch of these ones. We looked at one called toll-like receptor 4. And the reason is because one of the things this detects is that toxin I told you about way back in the first couple of slides called lipopolysaccharide. So a toxin that's produced by bacteria that in animal models you can inject into the brain and cause that animal to have a Parkinson's-like illness. So we wanted to see if measuring whether there were more of these receptors around meant that the tissue was being exposed to this lipopolysaccharide. And this is a similar one to the one I showed you with the tight junction proteins, again with the healthy people on top and the Parkinson's disease people on the bottom. And what we're looking at is this green color, and in this case you can see that the Parkinson's patients have more of the green color than the healthy people, which means that they have more of these specialized areas on the cells that are reacting to this kind of invader toxin. And there's a way to measure this. This is a beautiful picture, but there's also a way to measure it scientifically, showing that the Parkinson's patients have more of this. So then the next thing we looked at is, remember I told you that all the surfaces, inside and outside surfaces, are covered with bacteria. They're really important, actually, because the bacteria in the intestines, some foodstuffs you cannot metabolize. You cannot digest them without bacteria. They do the work of digesting the food. And so you need to have the right bacteria there. And so the way we did this study is we collected the stool. That's one of the things we collected. We also collected this tissue, and the tissue has bacteria that are attached to it. And then we looked at what genes were present, because these bacteria you can't just culture in a dish, because the intestines are a low oxygen space. And so it's very difficult to culture all the bacteria. So what we do is we do a specialized analysis of what genes are present, and we know what genes are present in different kinds of bacteria, so that's how we identify the bacteria. And it's not important the names of these bacteria, but the main finding is in this bottom panel here, that these ones here, so in this case, this is the feces, the stool of Parkinson's disease subjects. This is the feces or the stool of healthy people. And for each one of these bacteria here, the amount in the Parkinson's disease stool is less. So these are healthy bacteria, and the amount of healthy bacteria in the stool for these ones is less. And there have been now more than a dozen studies, and each one has shown certain of these bacteria. So this is one called Akkermansia that's increased in Parkinson's. These are unhealthy bacteria increased in Parkinson's, and then healthy bacteria that are decreased in Parkinson's. And again, the individual bacteria are not important here. There's not one rogue bacteria that's causing Parkinson's disease. What's important here is there are these kind of consistencies from study to study across different populations in different countries. And the findings are basically that the bacteria whose normal job it is to control inflammation in the gut, anti-inflammatory bacteria, are decreased in Parkinson's, and inflammatory bacteria are increased. So it's important, and it's across all the studies, so we think that this is a real finding. And now the other thing we looked at is, as long as we had pieces of tissue, we said, well, what the heck, let's just see if we can find this rogue protein, the alpha-synuclein protein in the tissue. And we, in fact, could find the alpha-synuclein protein in the tissue. We found it in people who we'd retrieved old biopsy specimens from, people we knew had Parkinson's because they were our patients, and we retrieved their old biopsy specimens. We saw this protein in the intestinal wall as early as 5 years before the onset of symptoms. The problem is that this technique was not very good, and other people couldn't replicate that finding. So it's not clear. We had initially thought that if this was a real finding, we would be able to, everyone's supposed to get a colonoscopy when they were 50 here in this country, that we could use it as a screening test, but it's not turning out to be a screening test. So what is it that we concluded about gut function in Parkinson's disease? So yes, people with Parkinson's disease have leaky gut. I do a little bit too. Second, that there is evidence of immune activation, inflammation in the gut. The third thing is that we think that the altered bacterial composition, remember, decrease in anti-inflammatory bacteria, increase in inflammatory bacteria, that altered bacterial composition favors inflammation. And then we're not so sure what to do with this question of the alpha-synuclein in the intestinal wall. That all makes sense? Okay. Now let me just say this. Association does not equal causation. It just does not equal causation. So these are associations. They're intriguing. They suggest that there may be ways to maybe modify these abnormalities and see whether they result in a change in the trajectory of Parkinson's disease. But this is all really kind of preliminary. And this is another complicated slide, just to keep you on your toes here. So now we've got the brain. This is where that protein that was seen in 1912 is, right up here. It's called the substantia nigra in the brain. And one thought is that what's happening is that you're having protein accumulation in the gut cells. That's what I told you about earlier. That then is spreading up the nerve. Here's the nerve that goes to the brain. I don't actually believe that. I actually believe that it's a different thing, that what's happening is that you're having inflammation in the gut wall that then causes inflammation in the bloodstream, and that's that inflammation that gets to the brain. But both of these two things would be speculative. Making that connection between what we see in the gut and what we see in the brain is premature. There's a lot of stuff there that I don't want. All right, and let me just go back to Hippocrates, who said, all disease begins in the gut. So it may turn out that Hippocrates is right for all disease. It's kind of interesting because a lot of this work, now we're talking about Parkinson's disease, but there's now work about how changes in the bacteria in the mouth are associated with development of pancreatic cancer. And we know that changes in the bacteria in the gut are associated with things like diabetes and cardiovascular disease. So old Hippocrates might be right. I want to spend a little bit of time, since that's all I'm going to talk about that research, just to get an understanding of why you would look at something and how you might look at something and how that could potentially lead to something down the road. I just want to talk briefly about what many of the people in this room are having, which is gastrointestinal dysfunction in the context of Parkinson's disease. Because that gastrointestinal dysfunction that starts in that prodromal period keeps getting worse. And so for patients, I had a patient with very late stage Parkinson's, more than 20 years. And his wife said to me, and he had dementia and hallucinations, and he couldn't walk, he had all kinds of problems. And his wife said, "Do you know what the biggest problem is for us?" And I thought, well, I'm smart, right? I'm a specialist. It must be the dementia. It must be the hallucinations. And his wife said, it's his constipation. That was a real lesson for me. So when we think of gastrointestinal dysfunction, there is drooling, abnormal swallowing, bloating is a big complaint, nausea, belching, abdominal pain, constipation, flatulence, problems emptying the bowels, and weight loss are all the things. And they're basically, drooling and abnormal swallowing relate to just, they're both swallowing problems. You're not making more saliva, you're just not swallowing it efficiently. But most of the other problems relate to slow transit. It takes a long time for food to get from one end to the other in the Parkinson's gut. Do I have that? No. Okay. And the longer it takes, the harder and drier the stool gets, and it just causes all kinds of problems. And the reason is because all those 100 million nerve cells in the wall of the gut, their job is to make sure that the muscles contract all the way down the pathway so that the food moves rapidly from one end to the other. So I'm just going to show a few little slides showing that drooling and dysphagia, so dysphagia means poor swallowing, are very common, and they get worse as the disease gets worse. No shock there. And from the and then upper GI dysmotility, about 60% of people, and what they feel is bloating, and they feel abnormally full after eating. And then constipation, which is almost 90% in some studies of people will have constipation. And then one that people don't often think about, which is difficulty opening the rectum and actually getting rid of the stool. That's a big complaint for people. It's even if they take a stool softener, they still can't empty their bowels. So we're just going to talk about it a little bit. So constipation is defined as fewer than 3 bowel movements a week. That's from the gastrointestinal literature. We found when we did a clinical trial trying to find a drug that helped constipation that a lot of people actually with Parkinson's have more frequent bowel movements, but they're incomplete. So they may have more than 3 a week. It's just that they don't empty their bowels as well as they would like. And remember that the constipation can begin years before the symptoms, the other symptoms. It takes normally, this is how long it takes stuff to get from your mouth to your rectum, 20 to 39 hours, that's normal. And in late stage Parkinson's disease, it can take up to 130 hours for food to get from your mouth to your rectum. And then defecatory dysfunction is problems with, it's kind of a complex dance when you empty your bowels. So you have to relax, you have to activate some muscles and relax others. And the other thing that can sometimes come along with defecatory dysfunction is incontinence, a little bit of loss of control of stool. And it's because of difficulty regulating the pressure of the anus, the sphincter that keeps you from losing control. And then also how you increase and regulate your pressure when you're trying to bear down and empty your bowels. So there's when your rectum is filling up with stool, and then both when you try to release it, there are problems with controlling that. And we're going to get to treatments. Treatment for drooling, I don't know, has anyone ever had botulinum toxin injections for drooling? It's a miracle. I know Dr. Hermanowitz uses this. That's helpful. In people who don't need that, sometimes chewing. The main problem is unconscious swallowing, so you're not thinking about swallowing, and the fluid will well up in your mouth and then come out the front usually. So if you suck hard candy or use sugarless gum, that triggers a swallow, so people will drool less when they do that. There are oral medicines that can dry up the saliva, and then botulinum toxin is a very effective way for people with drooling. For swallowing problems, We send patients to speech therapy, and they have very good recommendations, like the environment you should eat in. It's quiet and you're not distracted, you're focused on eating, you're not talking, you're not tired when you eat when your medicine's working, you sit close to the table, you hold your head up, you stay up after eating so that everything gets down. Take small bites, chew thoroughly, and swallow more than once. You take don't eat like this guy. Okay, short meals, but not rushing. And also that you clean your mouth after eating, because a lot of times if there's stuff hanging around the back of your throat, then sometimes when you breathe, it can drip down into your lungs. So there's lots of stuff there. And then there's some kind of practical approaches to constipation, smaller frequent meals, exercise, and we heard a lot about exercise. Exercise makes your bowels move better. Fiber and water. A lot of people with Parkinson's don't drink enough because they got to pee all the time, and so they don't want to drink enough. And then Beano can be helpful for people who got a lot of bloating or flatulence. I don't know, has anyone heard of Beano? It's just a liquid or tablets you can take. We recommend stool softeners, laxatives, sometimes prescription drugs. It's helpful. People don't realize this, but there's a reflex. When you fill your stomach, there's a reflex to empty your bowels. And so some people want to get up and poop right away. Makes more sense to get up, eat, and then poop, because then you're taking advantage of that. And then the squatty potty, which you can buy on Amazon.com, is a more natural way. So we're meant to squat when we poop, not sit when we poop. And if you elevate your feet with one of these little squatty potties, that makes it easier to empty your bowels too. This is just a list of other stuff that can be used. So some of the laxatives we use and prescription drugs. Sometimes we didn't hear about this kind of physical therapy. Where is she? But physical therapy of the pelvic floor is actually very helpful for our patients. And we have our gynecologists at University of Wisconsin have put out this wonderful thing called, what is it called? I don't remember, but it's a helpful training course for people to learn to control better their pelvic floor. This is the only recipe I give. I'm the Martha Stewart of constipation. So this is a recipe you can do at home where you use dried fruit and senna and brown sugar and lemon juice. It's delicious. I had a patient once who had to put it in the garage freezer because she ate it all day, and then she was pooping all day long. So you make this little concoction, and you put it in the freezer, and you scoop it out like sorbet. You could even serve it as a palate cleanser at your next dinner party. People ask about diet all the time, and let me just tell you, there's no proven diet for Parkinson's disease. But I recommend people see a nutritionist if there are concerns. Diet should be treated like medication. It really should be something you talk to your doctor about. We need more research on diet. But the diet that most neurologists are recommending for most neurodegenerative diseases is the Mediterranean diet. The Mediterranean diet does not use a lot of red meat. There's little red meat. There's no butter. In Wisconsin, this is a really hard sell, the low red meat and the no butter. Olive oil is the desired fat. And fish, as much fish as possible, chicken, whole grains, so don't eat anything white, whole grains, and fresh fruits and vegetables, and a glass of red wine if you drink. That diet has anti-inflammatory properties. That's the kind of basis for the recommendation, but it's not been proven in Parkinson's disease yet. It's also recommended for Alzheimer's disease by many providers. It's delicious. You can get it anywhere, and it's wonderful. And the other thing about exercise is exercise similarly has a kind of anti-inflammatory role. So that diet and exercise is very good. And people ask all the time about probiotics. We don't know what the right bacteria are. We don't know what bacteria put in the gut to make things better. So, to the extent that diet promotes gut health, things like kombucha, don't eat that slimy thing on the top, though. That is just gross. I think it's where the good stuff is, but it's gross. Sauerkraut, that's popular in Wisconsin. Certain kinds of dairy products, et cetera. So those are probiotics. They have fermented bacterial products in them, or prebiotics, which are fiber, the things that are already in that Mediterranean diet. So that's for the people who are already diagnosed, and then a little bit of a glimpse about how one would put together some research questions and a research program to try to answer that question. Is the gut involved in Parkinson's, and can we identify targets like inflammation, like intestinal permeability, et cetera? So now I am available for questions, but we'll have all questions, right? Panel.